I'm going to talk on evidence-based guidelines for management of priapism, or I think a better way to talk about it is the lack of evidence for the management of priapism. These are my disclosures, the same as before. However, I will disclose that I am the chairman of the AUA Priapism Guidelines, or new guidelines. So these are my objectives today. First, I'd like to review the process and development of the AUA guidelines. I think for me, actually, me and Nicole were in the exact same AUA leadership committee in 2017, and I chose to go on to the AUA guidelines program guidelines committee because I wanted to learn about what went into this, because we as urologists are actually using this in our clinical practice. So how does the AUA do it? And I'm going to share with you some of that right now. I also want to discuss the major challenges, the major changes, as well as challenges in developing guidelines for priapism where there really isn't evidence. It's all just sort of case control studies. This is what we do, and the outcomes aren't preset. In this talk, because I think I wanted to focus on something that I think we all see in our clinical practice, I will discuss mostly surgical management. So first, let's talk about the Practice Guidelines Committee. So the Practice Guidelines Committee actually is the group at the AUA that approves new topics, and it actually formulates and discuss how guidelines are going to be formulated and put together. For example, there may be a question, well, I'd like to have a guideline on upper tract transitional cell carcinoma or penile cancer or priapism. These are not common things. We take care of them, but they're not a common problem. So the PGC comes together to discuss this and ultimately reports to the Science and Quality Council. In order to develop a guideline, here are actually the stages. You've got topic nomination, you've got the panel is identified, you then go through a literature scope, you do extraction, synthesis of all of the data in the literature, you look at the evidence to support this, providing grades. We hear about A and B and C, you write, you then get peer reviewed by our colleagues, and then ultimately it's approved. This is important for everyone to know that actually the topics are actually provided by the PGC. However, it could be from an existing guideline, as well as there are online nominations. So everybody in this room can nominate something that they would like to see a guideline on. And ultimately, this is about how we in the AUA have to pay for this. This is expensive. There's a lot of work that goes into this to look at the evidence to support it. Importantly, the panel is identified. You have the chair. The chair then identifies the vice chair. We oftentimes will have patient advocates. So for example, in the priapism guideline, we actually have a advocate that actually has sickle cell disease as well as a history of priapism. And then we can add additional panel members. Importantly, your members of the panel cannot be conflicted, and at least 50% of the panel members cannot have a conflict. Extraction of the data. So this is can be a very daunting way to approach this. We on the panel come together with our questions that we give to the statisticians in the data analysis. They then pull all of the data from the questions that we propose. So for example, in the priapism guideline, we have 25 questions, and then they provide us with the strength of evidence to support our questions or our approach. We ultimately create a systematic review. We come together as a group, and then we move on to writing. This is also a daunting place because we have to put together a way to provide you with questions that you can use in your clinical practice. So what about priapism? I don't know if you realize this, but priapism actually doesn't have a guideline. This is a best practice statement from 2003. This is really old, and I will show you how this really is not relevant potentially to the practices that we have. We have a lot more new information. So this is why the PGC said that we need to have a guideline on the management of priapism, despite it being sort of almost an orphan disease. It's not very common. The other thing to keep in mind is that we have decided to partner with the EAU to do this. This is the first time that the AUA and the EAU are going to put together a joint guideline. This is sort of a statement, and no one ever made a difference by being like everyone else. I think you can kind of put this with each one of my talks, but this is sort of a new frontier, and there are challenges when you're working with another organization that has different practice patterns. So what are the major changes that I think will happen and impact management of priapism? Well, I think that you can break it down into three things that will change from the previous practice guidelines. The workup you will see is going to be a little bit different. Medical management of stuttering priapism is really going to look different, and we are going to offer you and provide you with information, and I'll show you that, as well as surgical management. That, I think, is where we'll focus our efforts. As you know, we have three types of priapism. You've got ischemic, also called in the past low flow, and you've got non-ischemic, or called high flow. Ischemic is an acute event by which the patient develops an erection greater than 4 hours without sexual stimulation. This is, quote unquote, the acidotic compartment syndrome that we all see in the emergency room. Now, high flow priapism, which I will not discuss, is a fistula from trauma, usually in the perineum, and this is often managed non-surgically. Stuttering priapism, which is a problem, especially in disease states like sickle cell disease, this is where you have recurrent episodes of priapism that occurs without sexual stimulation. Oftentimes people will wake up with an erection, and this leads to an acute ischemic event, which then leads to surgical intervention. So how can we prevent that? That's the question. So as I stated, acute ischemic priapism, this is a urological emergency. This is important that we address this in a timely manner, because I'll show you data later that the longer a patient has an acute event, the longer their corporal tissue is acidotic, is ischemic, and may lead to necrosis and destruction of that smooth muscle. So we oftentimes will identify ischemic versus non-ischemic by obtaining potentially an ultrasound to show no flow. Others have proposed getting an MRI to show no flow, but ultimately we in practice do a blood gas to look at the oxygen level, pH level. In the new guideline, we will be providing you with the evidence to support each one of these approaches. The new guideline will come out in 2021, so this is one of the major changes from the previous practice, best practice statement. How do we treat priapism? I think you will see in the previous statements that were done is that patients with sickle cell disease, we recommended giving them exchange transfusion, alkalization, oxygenation, and we even reported in there that a third of these patients will actually resolve. Well, what we now know, and the evidence would support, is that we treat special populations like that just like we treat an acute event. So what you will see now is the evidence to support this. We also have added to the guideline the management of patients, of both patients that are adolescents, children, as well as adults with sickle cell disease. And there will be a complete number of statements related to this. As far as stuttering priapism, this is where the field has made, I think, a lot of advances, and I've summarized it on one slide, but I think I don't necessarily give it as much. I'm doing a disservice to the work that's been done. But we've actually seen a number of studies that have looked at different oral agents to help prevent stuttering priapism. Things related to PDE5 inhibitors and special disease states such as sickle cell disease, and I'm happy to I will be happy to discuss that in detail later in our critique panel. Things like ketoconazole, where you are causing non-castrate levels, where you're reducing nocturnal erections, and this may lead to a reduction in stuttering priapism. I'd like to make the point that I believe, and once again, the evidence will show that we oftentimes use anti-androgens or GnRH agonists kind of willy-nilly. We will just say, well, let's give them, let's make them castrate levels. Well, that's a problem, because oftentimes we have patients that are young, they're of fertility, and this will prohibit them from having full sexual function, or actually cause them to be azoospermic. So I think what we need to do is we need to do a better job of coming up with agents that will take care of this. And then the last part of this is that there is now evidence to support that if you have a reliable patient, you can actually do intracavernosal injection therapy. So with phenylephrine to help at home, where you teach the patient how to do this, and they do this at home to help prevent the stuttering events. So this is a good way to approach this, and once again, we'll provide the evidence for it. But really, how do we manage acute ischemic priapism? Well, what you're going to see is that in the previous guidelines, we talked about aspiration and irrigation. Well, that's an old event. We don't irrigate patients. We don't inject saline and try to irrigate them. Really, the goal here is to we all know about placing our large bore needles into the corpora cavernosa, and then we aspirate to remove the old stagnated blood. This is an old slide from Greg Broderick, who's at Mayo Clinic. Here you can see where you have a dark blood, you're aspirating, and then all of a sudden you get down to your red blood. Once you have oxygenated blood that's present, now the receptors, those alpha receptors, are going to respond to phenylephrine, and actually you'll see contraction of the smooth muscle. So this is the key, not aspiration and then irrigation to try to flush out. So this is something that will also change. As far as what we do when this fails, well, this is where there's been a lot of innovation as it relates to shunting, and I'll talk about that more. But first, what are the goals of a distal shunt? The goal of a distal shunt is one, to reduce pain in that patient. We want to also preserve quality of life, i.e. erections. And as John talked about yesterday, that's the concept of reoxygenating the corporal tissue so it prevents smooth muscle atrophy and necrosis. And really, our goal is to preserve erectile function. Nelson Bennett, when he was a fellow with John at Memorial, Nelson is the co-chair of the new Guidelines Committee on Priapism, published this paper. And I think it's a really important paper because what it defined for us in the field is really the time points for which patients actually developed erectile dysfunction. And this is the percent of patients that had intact erectile function or no erectile function. So if you had an erection of less than 12 hours, 100% of people still had erectile function post. And if you had erections of greater than 28 hours, none of them regained erectile function. Importantly, none of these patients had a shunt surgery, and 28 out of the 39 actually had sickle cell disease. And they also had this history of stuttering priapism. This is important because stuttering priapism leads to acute ischemic priapism. So we have to address this. So what we've done is, in the new guidelines, we've asked the question, really, is does the specific type of shunt that you perform depend on the duration of priapism? So I'm going to propose for you the following. First, before we go into shunting, I think I'd like to acknowledge that the venous shunts, such as the Grahak shunts, we were talking about this last night at dinner, this is historical. This should never happen. You should never perform these shunts. They don't work and they have side effects. The distal shunts is where the majority of the advances have been made with the utilization of tunneling. And the question is, can we break down the shunts as it relates to timing? So I think we can all acknowledge that if you have priapism for 12 to 24 hours, you should be starting with a winter shunt, which is where you place the biopsy. It's a percutaneous biopsy through the glans penis. This actually is effective after you've aspirated and this patient has failed phenylephrine injection. So I would propose that this should be your first shunt if the patient has priapism between 12 to 24 hours. If you've got a priapism between 12 and 24 hours, you can also attempt the Ebbehøj Shunt, which is a surgical blade instead of the percutaneous needle. And this also has been shown to be effective. It's hard to interpret data from these earlier shunts because these were shunts that were done, some of them in the published literature is from 30, 40 years ago, where the endpoints weren't defined. So that's one of the major problems with coming up with guidelines for things for priapism. The Ebbehøj Shunt is a shunt that I would propose you should be starting with if your patient has a shunt of greater than 36 hours. This is where the distal aspect of the corpora cavernosa is excised, and you develop a fistula between the corpora and the corpus spongiosum. Now, this is where the field has moved. I would tell you the majority of the major sort of people that are seeing acute priapism episodes that are being transferred to our institutions, we now have added to our shunts the utilization of tunneling. This is a concept that two people, Tom Liu at UCSF and Bud Burnett at Hopkins, have proposed, because at the base of the penis, you have this old stagnated blood. In the past, when I was a resident, we called it crank oil blood that was there. And what you have to do, if you do a distal shunt, you have to get down to that proximal to help break that up to restore blood flow. So what you use is a Hagar dilator or a urethral sound, and you tunnel through the distal aspect down to the crus to reestablish blood flow. This could be done with the T-shunt, which is Tom Liu's, where you place a blade in, you then turn away from the urethra, and then you use a urethral sound. Tom says that you could do this in the office without anesthesia. I will tell you that has not been my experience, unless you have maybe sedation possible in your office. And what he's shown is that this approach you can actually restore erectile function. He reports as high as 50% of his patients that undergo this procedure can preserve erectile function. Now this is called the snake. Bud Burnett and actually myself have published on this, where you actually do an Ebbehøj shunt and then you use a large Hagar dilator, the same dilators we use when we place an IPP, and you tunnel this down. 100% of our patients have ED with this. Why? Because the Hagar dilators are large, you're destroying the tissue, and therefore are unable to reestablish this. These are the two papers that sort of look at that. This is from our group. This is from Tom Liu, and these are the papers that show both techniques and the end result. I want to tell you that proximal shunts also should never occur. Now that we have distal shunts with tunneling, where we're able to remove that old blood at the crus, proximal shunts should not be performed today, and the guidelines will reflect that and show the evidence against this. So that's one thing to keep in mind. In the last 2 minutes, I want to talk about placement of a penile prosthesis at the time of an acute ischemic event. Because this is a joint guideline between the AUA and EAU, this is really important, because the EAU actually already puts in their guidelines that this is grade B level of evidence, that they're recommending this at the time of IPP. So what is the perspective, or what is the rationale for this? Well, it's a situation where you have a patient that has an acute event. You then, and this is after 36 hours, so let me make that clear. The EAU says after 36 hours, you should consider placing an IPP. Why? Because those patients are not going to regain erectile function. So why not place it at the time that you're managing it? But the issue is that because this is such a disease where the incidence is so low, we don't have a lot of good data, like, for example, RCTs that Nicole talked about. How do we provide evidence for this? And what has happened is there's a group in the UK that is a tertiary center that has published extensively on this. So what are the benefits? Well, it would prevent corporal fibrosis, which would then prevent penile shortening, and actually it would get rid of the pain, and you would treat the ED at the time of the shunt. But the issue is the complications are high. The infection risk has been quoted by the group in the UK to be as high as 7%. They have erosion rates as high as 12%, mechanical device failure, and psychological distress on the patient and partner. Now, they published this paper which they looked at early and late placement of an IPP. And the conclusion is that if you do it early, the patients are more satisfied, and if you do it delayed, they're dissatisfied. The problem is that this is a retrospective analysis, single center, high volume center that does this and people are sent to them knowing that they're going to get this. There's a major selection bias because everything is skewed to the immediate placement. And really, what are the meaningful endpoints here? Is it patient satisfaction? Is it revision surgery? So let me tell you about the experience at Hopkins from two surgeons that have a lot of experience taking care of priapism as well as IPPs. We've done it in 12 patients, and all patients had an acute ischemic event greater than 24 hours. They were actually, some of them were as much as 3 to 4 days, and they all failed a conservative management and had unsuccessful distal shunting. This is kind of summarizes the data of what we found in our series. We actually had 5 patients that had erosions and distal extrusion of their IPP. And this is in a high volume center where we are, I would argue that we have a good idea of how to do this. The other perspective is that if you have an experienced prosthetic surgeon, we have tricks in our toolbox that would allow us to be able to place an IPP post priapism. Is it an easy placement of a prosthesis? Absolutely not. However, if you have an experienced surgeon, this is easily feasible. So in summary, we are attempting to address the knowledge gaps in management of priapism, in particular the workup, the management of stuttering priapism with oral agents, and the surgical management as I've described. Thank you very much.